That'll be good. So basically, the floor is yours, and kind of do what I want with it, and then we'll obviously towards the end we'll probably do some engagement, but basically you can take as long or as little as time as you want.
Great. Can you see my slides?
Yes, that looks great.
Awesome. Great. Well, thanks everybody for joining. For those of you who I haven't met yet, my name is Joy and I'm one of the outgoing fellows. And what I'll be talking about is what I learned in England. So I got to spend the month of May with these three wonderful folks, primarily Professor Adam Watts, who subspecializes in elbow, Mr. Sumit Talwalkar, Mr. Mike Walton, who did hand and shoulder respectively. So just a quick background of where I went. I was based primarily at the Wrightington Surgical Center, which is about 40 minutes outside of Manchester, about 2 hours from London by train. Um, and while I was there, I had a wonderful opportunity to explore the UK in terms of both their healthcare system as well as their culture. For Wrightington Surgical Unit, their claim to fame is, in addition to Professor Adam Watts being there, is that it is where Sir John Charlie invented and performed the first total hip arthroplasties. In fact, he still has his original OR there, as you can see in the top left. That's where he performed the first total hip, as well as all of the models of the iterations of implants since then. This is what it looked like on the outside, and to be quite honest, the hospital hasn't changed too much since that time. And this is Professor Charlie's original chair that I had the opportunity to sit in the workroom. That's still there. These are other examples of the many iterations of arthroplasties, everything from DHSs to different types of polys and total hip implants that were trialed there. This is how they listed their implant complications. It's on a string table in the top left, and then how they tested their implant, where it was the fellows in between cases would go out to this manually powered machine where they would perform load cycles on different polys and acetabules. And this was the first total elbow arthroplasty. He did experiment with many other joints as well, but this particularly interesting. The other hospital that I got to work at was actually a private hospital that was about 20 minutes south of Manchester, or if you're me and trying to drive in the UK, about 2 hours from the other hospital. This one is purely private. It's for insured patients, and they have a beautiful new facility and an MRI machine. So just to compare quickly between the public and private systems in the UK, for the two hospitals that I got to see, in order to obtain an MRI scan for the private hospital was same day as a new consult. They had a scheduled MRI and then same day image review. In the public system, it was about 4 to 6 weeks to get an MRI for a cuff repair, 1 to 2 weeks to get on the OR schedule if you're an operative candidate, and then about 6 to 12 months in a public system for elbow arthroscopy. Again, 1 to 2 weeks, 6 to 12 months again in the public system. For arthritis in the private hospital, they actually did not do total elbow arthroplasties in the hospital because they have limited resources, mostly an outpatient surgery center. And then in the NHS system, it was an average of 10 to 14 months. For fracture, they were able to get patients in a little bit quicker in about 1 to 2 weeks. However, all care in the public system is already included in your taxes, whereas in the private system, you have to have private insurance or pay out of pocket. And I'm sorry, I switched to the last row, but the annual surgeon pay in the public system is about £120,000 per year salaried. And this includes call, whereas in the private system, you're able to bill on a similar fee for service model. So lesson number one for me was that in the UK, surgeons are referred to Mr., not doctor. And this is because of their history with barbers becoming proceduralists who did surgeries versus doctors who were medicine and internists. So one thing that they said is that after the medical students matched into a surgical subspecialty, they'll proudly take a Sharpie and scribble off doctor and write Mr. on their white coats. Second lesson that I quickly learned is that there's a fair amount of red tape in the hospital systems that I worked at. I did have to get consent in order to shadow and be able to see every patient encounter. And as such, I was not allowed to take very many intraoperative pictures, if at all. So I apologize for that. This talk mostly based off of papers and other pictures that I was able to gather. So lesson number 3 was how not to drive. In fact, you drive on the on the left side of the road, and it took me a couple of tickets to figure out some of the confusing roundabouts. And that some of the roads are one way, two direction, and you have to have your wheels hanging off in order to get by the car that's passing by you. All right, now for the meat of the talk, I'll be going over some of the main lessons that I learned on elbow, including elbow instability, arthroscopy, including a matched hemiresection technique, some of the CMC implant arthroplasties that I got to see with Mr. Sumatalaker, as well as Professor Watt's distal biceps repair. So starting with simple elbow dislocations, I'd like to credit Professor Watts for some of these slides. The approach to simple dislocations is fourfold. First, to understand the anatomy, understand patterns of injury, come up with an algorithm for management, and then one stable immediate mobilization in order to help get the best outcome with limited stiffness and a stable joint for the patient. Schreiber has taught us that overhead mobilization neutralizes distracting forces across the elbow, with gravity compressing the ulnohumeral joint and allowing for increased stability, and allows for less tone in biceps and may be helpful for early immobilization. So for simple elbow dislocations, the natural history is pretty good. 92% have stability, and about only 8% have persistent symptomatic instability. However, 40% of elbow stiffness continue to have elbow stiffness or pain. And the question is, who are these bad predictors, and what are ways that we can differentiate patients who will ultimately have a good outcome from those who will have recurrent instability? Now, for just to preface this, any simple elbow dislocation, you're allowed to have flex off the medial and lateral elbow condyles, but you are not allowed to have any bony avulsions off the coronoid. So thinking about elbow anatomy, the elbow isn't a symmetrical joint. It's composed of bony stabilizers, ligamentous stabilizers, and dynamic stabilizers, including the common flexor origin, the common extensor origin. The medial side has a bony congruity through an arc of 180 degrees, and the lateral side has bony congruity through only 90 degrees and relies on ligamentous and dynamic stabilizers akin to the shoulder. So it's really important to keep this in mind, the difference in the source of stability between the medial and the lateral side, particularly when treating these patients. You also want to think about the extrinsic forces across the elbow, including the triceps, the biceps, and the brachialis, the common flexors, and the common extensors, which provide a joint reaction force compressing the proximal form into the distal humerus throughout the range of motion. A study by Schreiber looked at MRIs in patients with simple elbow dislocations and found in the medial collateral, found that patients with posterior lateral injuries typically had a hyperextension in valgus force as they dislocated their elbow, and as a result, they are most likely to have MCL injuries and less likely to have injuries across the lateral ligamentous complex. However, the problem with the study is that they only did MRI on small portions of patients with elbow dislocation. There was a potential selection bias. So Professor Watts did repeat in the study and performed a prospective MRI study of posterior lateral simple elbow dislocations, which is the most common type in about 80 to 90% of patients. And they did this for 17 consecutive patients across 2 years. They found that for patients similar to the Schreiber study, patients with posterior lateral dislocations all had an MCL injury. Many had a lateral complex injury, but what was differentiating between whether they were stable after reduction versus recurrently unstable was whether there was an injury to the common extensor origin. So if you organize these patients based on injury patterns, you'll see that simple elbow dislocation does tend to have a severity scale, starting with the medial collateral ligament, then progressing to the lateral collateral ligament complex, then common flexor origin, and the common extensor origin. And as such, he came up with the ladder of injuries for simple elbow dislocations, starting with medial and progressing to the lateral ligament, then common flexor, then the common extensor avulsions. And he found that grade 4 injuries, so everything disrupted, including the common extensor origin avulsions, these patients tend to be the bad actors and would have recurrent instability and stiffness when managed non-operatively. So his preference was to manage these surgically. And when he did manage these surgically, he would start with the lateral side first and then fix and then reassess and then fix the medial side as if going down each rung of the ladder. So his findings were also replicated with other studies looking at radiographic correlations of lateral-sided injury structures. So in this study by Shensky, with an examiner anesthesia, he used fluoroscopy to evaluate for stability. And he found that with patients that got more than 10 degrees laterally, which commonly indicates insufficiency of the lateral ligamentous complex, as well as the common extensor origin, these patients were predictive of having 6 times greater risk of clinical instability and ultimately decreased elbow extension, lower Mayo elbow performance scores. So if MRI is not readily available, as in the private hospital system, we can use a fluoroscopic exam and look for that gapping of 10 degrees on the lateral side as a predictor of instability. Adolphson et al. Also looked at simple dislocations and found that patients with recurrent instability also similarly had common extensor origin insufficiency as listed in these 8 patients. Interestingly, it's also important to note that although posterior medial dislocations are rare, accounting for about just 10% of simple elbow dislocations, they are disproportionately recurrently unstable. And this is because these follow the Horry cycle in which the medial-sided structures, so the medial collateral ligament remains intact while everything ruptures starting laterally, going anterior and posterior and hinging around medially. So it's important to remember that with posterior medial dislocation, you're much more likely to tear the important soft tissue structures on the lateral side, which is already relies on the dynamic and ligamentous stability. So 2 examples of patients. So patient A has intact lateral side ligaments and soft tissue. This patient would be treated non-op. However, in patient B, who has lateral and medial disruption, including the common extensor origin, he would fix this. And for both, they would get immediate active mobilization. So things to remember about simple elbow dislocations is a spectrum of soft tissue injury, and it's important to consider further imaging in those patients with significant displacement on X-ray before reduction, incongruent joint post-reduction, patients who are reluctant to move out of a splint after reduction, or bruising, significant bruising on the lateral side of the elbow that may indicate a common extensor origin disruption. And that instability pattern of lateral side instability is also a spectrum in and of itself. So for more chronic injuries, the posterior lateral rotatory instability pattern progresses to a radial head fracture, and ultimately a terrible triad as there's more forces applied across the elbow. So when thinking about chronic injuries such as a PLRI, which is also the most common pattern of rotatory instability, the MRI can also be helpful, but it's important to not just rely on radial head subluxation alone, because there is a wide variety of what's normal, what's not normal, but it's looking at ulnohumeral gapping is potentially a better predictor of instability, because in patients with a stable elbow, there will not be significant gaps in the ulnohumeral joint. Also, it's important to look for an Osborne caudal lesion, which is basically a small banker off the back of the capitellum, which reflects an important ligamentous injury to the posterior lateral ligament. This can occur even in the presence of an intact lateral ulnar collateral injury and is associated with subtle instability. So Professor Watt's team did cadaver work and found that the posterior lateral ligament arose from the posterior aspect of the capitellum, just immediately posterior to the articular cartilage and anterior to the anconeus muscle origin. The ligament's distal attachment is on the lateral edge of the supinator crest, just proximal to the attachment of the annular ligament, and it blends with the bony attachments of the supinator and the ECRB muscles. All of this is just to say the importance of the posterior lateral ligament is that it creates a hammock behind the radial head that limits posterior translation. So in this fashion, it's a primary stabilizer of the radial capitular joint against posterior subluxation, which can be assessed with the posterior drawer sign. And together with the LUCL helps to provide stability to the lateral side of the elbow joint. In a recent biomechanical study, they found that isolated tear of the posterior lateral ligament enables a significant increase in radial head posterior displacement compared with an intact elbow, particularly in flexion of 30 and 60 degrees. And an even greater displacement can be found with release of the LUCL along with the posterior lateral ligament, which we already knew. So signs to look for on the MRI for posterior lateral ligament avulsion is the acute angle between the posterior capsule to the articular cartilage on the sagittal. If there isn't a close relationship of the posterior capsule, then there's likely an avulsion of posterior lateral ligament. And on arthroscopy, that blurry image is my attempt to show that there will be a bare area just proximal to the articular cartilage. And with supination of the radial head can frequently subluxate into that posterior capsule pocket. So this is an example of a patient we saw in clinic with an isolated posterior lateral ligament avulsion. You can see the LUCL is intact in the far left image. You see some fluid as you scroll posteriorly. And then on the sagittals, you can see some fluid in the tendon sheath that may be a sign that something may be torn more further deeply. And then as we scroll even more posteriorly, we see that sharp angle between the capsule between the posterior aspect of the humerus and the capsule where fluid has extravasated. These are two more images showing it's possible to have an isolated posterior lateral ligament disruption with an intact LUCL. And then if this is avulsed with a small bony fragment, it's possible to use, for example, a headless compression screw to fix this back. If it's just an isolated soft tissue avulsion, then we can use an anchor to fix it back. So should we scan every elbow? Absolutely not, but it is important to keep in mind the role of the posterior lateral ligament because it can be an important pathology if the elbow isn't quite behaving the way you expect after a simple dislocation. This he divides into two grades, grade 1 with being a positive posterior drawer, negative pivot shift, with likely posterior lateral ligament avulsion and LUCL being intact. Grade 2, positive posterior drawer, positive pivot shift, which both LUCL as well as posterior lateral ligaments are involved. So treatment for this can do a Boyd approach if it's acute and fix with an anchor or screw. If it's subacute, he would do a lateral ligament imbrication arthroscopically to help tighten up the lateral structures. So simple elbow dislocations, remember the key differentiators. It's important to remember that posterior medial rotatory instability is most frequently unstable and requires surgical treatment, as well as going all the way up the ladder in the posterior lateral dislocations, including avulsion, the common extensor origin. Those will also likely require surgical treatment. Lesson number 4, not so simple, elbow fracture dislocations. So there's only so many ways you can wrench a forearm off of a humerus. You can rotate, you can apply a bending moment, or you can apply an axial load. With rotation laterally, you get a terrible tride. With rotation medially, you get posterior medial rotatory instability. With transverse bending moments and extension, you get a Monteja or transolecranon apex anterior fracture dislocation. With flexion, you can get a transolecranon apex posterior fracture dislocation. With longitudinal force, you can, across a flexed elbow, you get a Reddington B, which is a bifacet coronoid fracture. And then with an extended elbow, you can get an exoscleropresti injury. In all of these fracture dislocations, it's important to remember that the coronoid is the key, even though the radial head may be a distracting primary aspect of the X-ray. It's important to remember that that small coronoid plaque is what is very important to restore. And that is because the coronoid provides an anterior buttress to prevent the proximal ulna from subluxing posteriorly in relation to the distal humerus. There have been multiple classifications describing the coronoid, with initially the Regan and Moore classification, but it doesn't quite capture the location of the coronoid fracture, which is important in the following slides that I'll explain in the three-column concept. The O'Driscoll classification does a much better job of capturing the three-dimensional nature of the coronoid, particularly with how much of the coronoid is involved from a clock face perspective. And it's a much better way of looking at what coronoid fractures would need fixation or not. So in Wrightington, I learned about the three-column concept with looking at the proximal forearm divided into columns with relation to the distal humerus. The fulcrum for stability lies between the medial column and the middle and lateral columns. And so these correspond to, with the medial, the anterior-medial facet, and then the fulcrum. And then the middle would be the anterolateral facet of the coronoid, and then the lateral column would be the radial head. So if you think about this, anterolateral coronet facet fractures isolated themselves are very rare. They are frequently just JSES case reports. And if you take away just the anterolateral coronoid, you'll still have the medial and lateral aspects, which is the anterior-medial facet as well as the radial head. And as such, these patients tend to continue to have a stable elbow and do not need surgery. And you can see by that little balanced guy that he's still balanced up there. With radial head fractures such as Mason 1 or Mason 2, these can be treated non-op because, again, the elbow maintains stability through the rest of the bony and soft tissue structures. Your anterolateral facet is still intact. Your LUCL or lateral ligamentous complex is still intact. And so these can compensate for a small radial head fracture. However, in a terrible triad, when you take away the anterolateral facet as well as the radial head and lateral collateral ligamentous complex, we're thrown off balance here. And so the way we treat this is to fix the radial head, and you do not always have to, fix the lateral collateral ligament complex, but you do not always have to address the anterolateral facet because we're balanced once we bring back the radial head and the lateral ligamentous complex into the equation. With posterior medial rotatory instability, we're taking away the entire medial column, so the anterior medial facet of the coronoid. And with this, we're thrown off balance again. And so the treatment for this is to fix the coronoid, fix the lateral ligamentous complex, and that would help us restore stability. So this brings us to the Wrightington classification of the elbow fracture dislocation patterns, and I'll be going through these systematically, but this is a way of both radiographic characterization of the different elbow fracture dislocation patterns, but also a stepwise approach to what to fix when. So for type A, which is an anterior medial facet fracture, these are your typical posterior medial rotatory instability type pattern. There have been multiple different treatment algorithms that have been developed to determine indications for surgery, as well as when to fix what and in what order. However, there still remains a fair amount of debate. And it's hard to elicit subtle instability early on enough so that we can prevent the rapid arthrosis. Because if anterior medial facet fracture is missed, there's abnormal biomechanical loading forces across the elbow, and this can result in rapid arthrosis even in the span of 1 to 2 years, and this would be very sad. So for anterior medial facet fractures, Professor Watt's treatment algorithm is to restore the bony buttress either with screw fixation or a buttress plate. And then he would frequently also fix the posterior bundle of the medial collateral ligament to help provide additional rotatory stability. So that's the anteromedial classification. For bifacet, for Wrightington B, these are your transolecranon fracture dislocations, your bifacet basal coronoid fractures, and your that may or may not involve the radial head. So for these fractures, he subgrouped these into apex anterior versus apex posterior Montesia transolecon fracture dislocations. And the algorithm here is to fix the coronoid, fix the medial ligament piece with independent lag screws if possible, and then if needed, fix the radial head if there's a fracture there, and then fix the lateral collateral ligament complex. For apex posterior fracture dislocations, which are frequently much worse fractures, he would fix the coronoid through the fracture, fix the radial head, fix the lateral collateral ligament complex, and then restore the normal ulna alignment by getting contralateral films looking at the posterior ulnar diaphyseal angle and the bow and restore osseous stability. For B-type, B+ fractures, in which you have both radial head partial fracture dislocations as well as coronoid fractures, and fix the coronoid, fix the radial head, and then fix the lateral ligamentous complex. For the combined comminuted Wrightington class C fractures with the anterolateral facet of the coronoid as well as radial head, his treatment algorithm was typically to fix the radial head and the lateral ligamentous complex, and if needed, evaluate and fix the medial-sided structures. So these type Cs are your typical terrible triad, which follows the algorithm that I just stated. If it's a large coronoid fragment, he would also fix the coronoid. But if it's a small bony avulsion, again, we're thinking back to the 3-column concept, we may not need to fix that coronoid as we have enough osseous and ligamentous stabilizers without it. A couple tips on radial head arthroplasty. You should align the radial head with the mechanical axis, which is to the ulnar styloid. But if we're just looking at a view of the elbow, one radiographic parameter is to point the radial stem, the radial head stem, at the distal aspect of the radial tuberosity. And so as you can see here in one of the cadaver labs that we did, this is a fluoral image of the optimal alignment for where the radial head implant should be. It's important to not overstuff, as we have learned from previous studies that any ulnar humeral joint gapping is overstuffing of the radial head. And you want to match the ulnar variance, and you want to match the radial head height with the proximal rim of the PRUJ. For Wrightington class D, which is a diaphyseal ulnar fractures with or without radial head fractures, and these are diaphyseal ulnar fractures distal to the coronoid. It's important to fix the ulna, fix the lateral ligamentous complex, and fix the radial head if necessary. So, and this is an example of one of those patients. So, ultimately, that together brings me to another topic that I learned about, which is Professor Watt's arthroscopic management of the arthritic elbow. And one of the main one of the procedures that I saw frequently was actually a matched hemiresection of the radial head for the radiocapitellar joint arthrosis. So the indications for this procedure are primary symptomatic osteoarthritis of the radiocapitellar joint. These patients present with lateral-sided pain, positive grip and grind tests, and this is where you hold the patient and you basically give them a handshake by grasping their fist, and then on this, you grind their elbow as they're giving you resistance to a proximal displacing force. And this allows for co-contraction of the common flexor and extensor. These patients who underwent matched hemiresection typically had radiocapitellar narrowing with a preserved ulnohumeral joint space. So the ideal patient is a young heavy laborer. So for these, he would do arthroscopy with 6 portals, starting with a midline posterior portal located about 4 centimeters proximal to the olecranon tip, and then a proximal posterior lateral portal located just lateral to the posterior portal at the lateral edge of the triceps tendon. And then he would do that to help evaluate the posterior aspect of the ulnohumeral joint and take down any osteophytes there. Then he would proceed to establishing the lateral portal, as well as viewing from the proximal anterior medial portal, and then using this to perform a matched resection of the radial head. So what that means is that he would take about 4 millimeters off the radial head, just flat across, and then 8 millimeters, so that ultimately the radial head forms a bowl shape and does not have to articulate with the arthritic distal humerus. And at the end of the procedure, the radial head's concave surface would match the shape of the capitellum with a preserved large joint space. So he's studied this and found that patients with this procedure tend to have preservation of their radiocapitellar joint space, even up to 5.5 years post-op. This is a series that he wrote, which out of just his initial 8 patients performing this procedure, he had about 75% success at 1 year. But the indications are really strict, and it's for patients who are primarily symptomatic with the grip and grind test. I know I'm running out of time, so I'll go over these last 2 lessons a little bit more quickly. Also got the chance to see some CMC implant arthroplasties, particularly with the Carry Medical Touch prosthesis, which is a bipolar dual mobility CMC implant prosthesis, which has the advantages of maintaining thumb length, improving pinch, and based on their studies thus far, has an overall complication rate of 5.4%, primarily of dislocation risk. And from just the monopolar implant arthroplasties, we know there's some literature from Europe showing an 83% survival at 5 years and 50% survival at 30 years. So overall, pretty good data for implant arthroplasties across the pond. So when performing CMC implant arthroplasties, it's important to obtain the correct radiographic views. These are examples of the Betz view and peritrapezial view that allows you so from left to right, the Capongelateral, the middle is the peritrapezial view, and to the far right, the Betz view. And this allows you to evaluate for the presence and size of the volar beak osteophyte, and allows you to appropriately place the metacarpal stem in the volar to dorsal plane, as well as put the trapezium cup perfectly in the center of the trapezium. The approach is a standard dorsal approach, and here you can see that it's important to excise all of the soft tissues at the base of the metacarpal, so you can subluxate the metacarpal dorsally in order to allow for correct metacarpal implant placement. So after the capsulotomy, the base of the metacarpal is exposed circumferentially, releasing all of the ligaments tethering dorsally. And then you can use the cutting guide on the metacarpal base, and you have an assistant holding the metacarpal shaft parallel to the floor during the cut, so that the angle is matched by the handle and the resection guide. One of the frequent pitfalls is having the cut of the base of the metacarpal being oblique to the shaft of the metacarpal, which is one of the early reasons for frequent dislocations found in some of the older studies. Once you have this done, you can distract the joint and remove the volar beak osteophyte. And you can do this with an osteotome about 45 degrees to the long axis of the metacarpal. And here you can see the osteophyte removed, and moving the thumb to an abducted position will not result in any impingement after you remove the osteophyte. And then it's important to remember that if you do remove the volar osteophyte, it's important to put the guide wire for the metacarpal more towards the center instead of in the dorsal third, as per the manufacturer guidelines of the metacarpal, because you have removed the volar part of the metacarpal already. And so you don't want to perforate the dorsal cortex by placing the metacarpal stem too dorsally. So these are examples of some of the interactive pictures. And with the stem being this in this particular picture, it's still a little bit more dorsal than what I saw in the operating room. And so for this patient, they happened to get lucky and did not have dorsal cortex perforation, but ideally you would start the awl a little bit more volarly. So here's another example of placement of the metacarpal implant for the arthroplasty. And you can see that a lot of soft tissue release was performed in order to appropriately dorsally sublux that metacarpal for the placement. In addition, with that soft tissue circumferential resection, you're able to depress the metacarpal for accurate placement of the trapezial cut as well. So when you're placing the trapezium implant, you want to think of the trapezium as a clock face. And so before placing the guide, I want to make sure that you're hitting the exact center of the clock face, and that you want to extend the capsulotomy from the dorsal surface to the lateral and medial horn. So from 3 o'clock all the way to 9 o'clock, so that you can reduce the chance of any soft tissue impingement, as well as allow for accurate placement of the trapezial cup. Professor Sumedh Talwalkar always chose the smallest implant for the trapezial cup, because he said that you could always upsize with any instability, but you can't downsize. And already the bone quality is pretty poor in the trapezium. So that's another takeaway that I got there. So these are pictures of the trapezial implant being just sized prior to insertion and broaching. And then also guide wires showing you can just use guide wires to help localize your location for the eventual broaching for the trapezial implant. In terms of trialing, he would perform 4 tests each time to evaluate the stability of the implant. Number 1, Kapanji thumb opposition. You want to make sure they can oppose to the MCP joint of the small finger. Number 2, he would look at the shuck test at rest, and then at maximal longitudinal traction, you should be able to pull the implant completely out of the socket. Otherwise, it would be fixed too tightly. 3, the reduction should be easily achieved with just fingertip strength on the reduction instrument. And number 4, you would simulate a push-up test where he puts his thumb at the base of the metacarpal and pushes up as if the patient is pushing themselves up out of a chair, and ensures that there's no dislocation of the component. With the last couple of minutes, I'm going to share some pearls on Professor Watt's technique for distal biceps repair through a case presentation. I did present this very briefly at a case conference several weeks ago. So I'll just run through this quickly. So this is, for example, a 48-year-old male, right hand dominant, classic history, eccentric load, injury while carrying boxes, and he has this proximal migration of his biceps muscle. He had a positive hook test and also a positive bicep squeeze test, which is akin to the Thompson test for the Achilles. You squeeze the biceps and you look for any supination. Lack of supination likely indicates a distal biceps rupture. He frequently would also get a FABS MRI if available, because this allows you to look for the distal biceps in the plane of the tendon, and allows you to better evaluate for partial ruptures as well. And his ideal approach was actually the transflexor pronator approach, and with an accessory incision more medially for cosmetic reasons, proximally to retrieve the retracted tendon stump. For this approach, he would go along the sheath of the pronator, and then travel along the muscle belly to avoid dissection around all of the plexus of veins in that area, and then follow that interval all the way down to the radial tuberosity. So here's some intraoperative pictures. The hand is to the right of the screen. The elbow is proximal, medial is superior, and lateral is inferior, showing the flexor, the pronator fascia that is carefully dissected layer by layer. Here's the venous, a big vein that is in the field that we are staying just lateral to. So there's the interval that we're in. We're staying medial to. We're staying medial to all of this to try to avoid dissection into the plexus of veins. And then here we are retracting a little bit more deeply. You can see the muscle belly itself, the muscle fibers being peeled off of the fascial enclosure, and then followed all the way down to expose the bursa over the radial tuberosity. I saw this several times. It was very quick with the appropriately placed incision. And from there, his preparation of the radial tuberosity, his preference was actually to do a transosseous tunnel using 2 drill holes and then a ronger to connect the proximal cortex drill hole to avoid the risk of amputating the distal biceps tendon as you insert it in from the sharp edges, as well as creating enough of a trough so that the distal biceps tendon can seat inside the bone. And then he would prep the distal biceps using Bunnell sutures going up and down either side of the tendon, and then loading it into a button, inserting the button through the radial tuberosity with maximal supination. This is important because you don't want to risk going outside of the safe zone, which is just 30 degrees directly dorsal to the radial tuberosity with maximal supination. Otherwise, you can risk injury to the PIN. And with this approach, he was able to easily tension and allow for a very anatomic footprint of the distal biceps seating into the radial tuberosity. And this is what his final construct treatment looked like. Some pearls and pitfalls for this approach. It's important. He would inject lidocaine and epinephrine and not use tourniquet. That way it can help him control skin bleeders while not deflating some of the large veins while doing this approach. When the veins are encountered, he stayed medial during dissection to reflect them with the sheath of the pronator. He did not tension the initial running Bunnell suture to provide adequate slack for the endobun to sit about 4 millimeters from the tendon step, so that it allowed for enough wiggle room as it went through the radial tuberosity. One trick, because they didn't have different colored sutures readily available in their ASC, you would load the leading and trailing sutures onto the tonsil and beef pin in opposite directions to help keep them sorted. Some pitfalls are that if you fail to dissect layer by layer through the flexor pronator sheath, you can risk injury to the venous plexus and the antecubital fossa. It's easier to pass the endo button with that 4 millimeter gap, as I mentioned before. If you don't use a periosteal elevator or the roger to clear off the sharp edges from the drill holes on the radial tuberosity, you can risk amputating the tendon as you're passing it through bone. And then failure to maximally supinate the arm during passage of the beef pin, risk placement outside the safe zone of 30 degrees and PI entry. So with that, I think I'm out of time and I'll take any questions.
Hey,
That was
Joanne.
awesome, Julian.
Oh, Julian, you want to go first? You can ask some questions, and I'll ask some questions.
Yeah. I think my question is probably more centered around the CMC arthroplasty. Obviously, that's something we're all excited to be able to start using. What do you think's going to be kind of like the biggest challenge to learn, or like the biggest barrier to entry with that in learning the new implant, or being able to like kind of get the appropriate sizing for patients?
Yeah, that's a great question. That's something I asked Professor Tollocker about, and I think what their experience in the UK was actually with setting the appropriate tension. And that's why I kind of went over the four trial tests that he learned over time. You don't want to make it too tight because then they can dislocate from impinging. You don't want to make it too loose because then they can also dislocate. Obviously, these rates are lower with a bipolar prosthesis, but you want to make sure they have dexterity as well as stability, which is why the CMC joint is so tricky to develop an implant for. And so I think getting the adequate soft tissue releases while also getting the appropriate tension is going to be pretty tricky um, for um, for all of us as we learn how to use it.
All right.
Awesome.
Okay, Joanne, my turn. So, let's say you have a patient with a simple elbow dislocation, and they come to your clinic. They were reportedly reduced at an outside hospital. You don't have the X-rays of which way it was dislocated. They come to you, and you get plain X-rays. You don't see a fracture. Do you get an MRI or no? So,
Um,
what's your steps for evaluating the patient when they come see you now?
Yeah, absolutely. So for me, I would take them out of the splint, and I would, if they can tolerate it, try to perform a fluoroscopic exam. So if there's more than 10 degrees of gapping laterally, then I would be suspicious for um, a um, a significant injury. Of course, this doesn't rule out your less common 10% posterior medial dislocations. And so if the patient is still having stiffness, pain, difficulty mobilizing at their next follow-up visit, which I'll probably have them come back in just a week after mobilizing, and they found to be stable and they did not have that 10 degrees of gapping, then I would be suspicious for something more and get an MRI at that time.
Okay, so let me ask you this. So, someone that just had an elbow dislocation, do you think they're going to let you actually try and essentially gap open their elbow?
So likely not.
Right? There's
But
going to be so much guarding you probably can't tell.
mhm.
So, when and how do you decide whether or not you're going to get an MRI?
So if they have already been in a splint for several weeks, at the time that they come in, I would take them out of it. And then I think it's a tricky question for sure. Also something that I'll be trying to figure out. But I would see if they're stable under range of motion without the gapping, with just extension and supination.
And how far stable do they have to be considered stable? Right? So, let's say when you say someone's stable, how much extension do they have to be able to get before you say this is stable?
Yeah, so at least 30 degrees.
So, you think you're going to get someone all the way out to 30 degrees of extension when they first come in?
Not always for sure. And that's where I think it may be helpful to get an MRI, but I also understand that it's pretty hard for us in our system to get MRIs on everyone acutely.
Gotcha. Did Watts ever go over his rehabilitation protocol of whether or not he keeps them pronated, how much extension he allows at what time frame?
Yeah, for simple elbow dislocations, he's gone to immediate active overhead range of motion.
So what does he do on the periods of time when they're not overhead? Does he put them into a split, like a thermoplastic splint?
No, he doesn't believe in splinting at all.
So he just puts them in a sling?
Sling, if anything, but ideally just immediate active motion. Usually the patients can't tolerate it, so he would put them in a sling just to walk out of clinic.
Interesting. And
Mhm.
I'm assuming never a hinged elbow brace because he worries that it's not concentric.
Exactly.
Yeah. Interesting. Okay. Um, Yeah, I mean, obviously you can see differing in opinions of how things are treated and what they're done. I mean, the likelihood of us operating on a simple elbow dislocation is super rare. Often what I find, honestly, for a lot of these people is that once the elbow's been reduced, some of the ligaments go back to exactly where they are. And if there's like small avulsion flex with them, they often heal back, right? And so typically if you give them a few weeks, they'll often heal back. You don't actually have to surgically go repair almost any of them. It's the people that have chronic kind of PLRI or little subtle subluxations later that are a little bit harder. But part of me says, their range of motion's full and they're not actually issues. The only reason I ever use the hinge elbow brace for some of these patients is purely to prevent them from going past extension. I tell everybody your instability of your elbow starts to happen as you get past when you're closer to 60 degrees of extension, right? So if you're within 60, I don't expect anyone to get to 30 the first day after their stuff. So from 60 degrees onwards of flexion, right? So if this is zero, this is let's say 45, this is 60. If they can get to 60 and fully flex, then I know that they're probably going to be okay. And so then I say, okay, look, because at that point it's when the trochlea starts to engage, essentially from the flexion where essentially your area on the olecranon will start to engage on the trochlea, and then you actually get more stability. So as long as they can get to within 60, that will keep them stable and less likely to dislocate. And then I say, okay. So slightly little difference, but I will tell you it's pretty rare that you have to fix a simple elbow dislocation, even when you look on the MRI and they have everything torn, because oftentimes most of those ligaments will come back and scar in if you hold them still for a week or so. But I just find it interesting because obviously, right, getting an MRI in England is probably more expensive or more costly to them than even the US is. And the US would probably order them, and I would not routinely order an MRI on a simple elbow dislocation. Not necessarily. Now, half the time they show up to the clinic because someone else has ordered them, which is okay.
Yeah, for sure. I
Joanne,
think, sorry.
can I ask a question to that? Did you find that he was doing those surgeries on the private patients over did he work in the public system as well, or he's just private?
Yeah, Dr. Zung, you touched on my exact next point. And so I feel like where that 17 patients that were done prospective, that got the prospective MRIs for simple elbow dislocations, most of those did come from the private side where they had an MRI machine in the same building. And they would go get that MRI, come back, and they would discuss management. And so that's where that study, some of the data from that study may have come from. However, I can't say that for sure. But he, for a long period of time, he would just manage the simple elbow dislocations, also just evaluating for stability under fluoroscopy.
Did you get a sense of like what was really driving him to start treating them so aggressively?
Yeah, because he saw recurrent instability and he wanted to see why, like understand why some patients did well after simple elbow dislocations. Well, most patients did well after simple elbow dislocations, and who were the ones, like what were the reasons, anatomical reasons for why some patients did not do well. And for him,
Ironically, I feel like the people that have the highest risk for repeat instability for simple elbow dislocations are morbidly obese patients. That's
Oh yeah.
typically what I find.
for sure, yeah, it's a huge various.
Keep in mind, Nikki, they don't use the IGS ever for anything.
Yeah.
And it's not to say he doesn't believe in it. It's just so expensive they never put it in, even in their private patients.
Yeah. I mean, it's interesting. It's an interesting concept because like basically the terrible I've never treated, well, that's not true. I've treated two simple elbow dislocations surgically because they both had brachial artery injuries. But other than that, I've never treated one surgically. But like for my terrible triad patients, if they have that huge like extensor mass, like a avulsion, those are the patients where I'm like, I'm just going to put an IJS in because I know it's going to be super unstable. So it does make sense, but I don't know how much it applies to these simple ones.
And are you fixing the common extensor origin as well?
Yeah.
Well, that's the whole point, right? So essentially, your IGS goes over all of those ligaments being pushed back up from the ligament. We just never put a little screw in because the irony is that to get a screw in that piece, you essentially have to take all the soft tissues off of it to get the piece of bone back to your L's, your essentially your post, which I Look, you can call it whatever you want. I just call it part of the LUCL complex, right? It's all of that part is the lateral collateral ligament of the elbow, which is essentially is it the radial collateral ligament, which is more anterior or more posterior, or the whole complex. The argument that I have is that if you have a small little bony avulsion and you're trying to put a screw in it, you essentially have to devoid it of all the soft tissues that were on it. So, like to me, that's very hard to do because
No,
otherwise,
I don't mean the ones where they're like there's that avulsion piece off. I just mean where like all of the soft the whole whole soft tissue sleeve just kind of like comes
yeah,
off.
but I mean, I repair all that stuff back and try and use it as the
Yeah.
quote unquote hammock back up. But I put the IJS over all of that, which essentially just compresses it all back up into that area. It's the same
Yeah.
type of concept. It's just how, a couple of varying different ways. But that's the beauty of going overseas, right? And seeing how other people do stuff to the elbow and what they do and how they do it. That's the beauty of it.
Yeah.
I'm not sure, I'll be flat out honest. I think Watts is incredible. I think the olecranon classification super helpful. I think the like fracture dislocation classification is kind of like nonsense because there's so many different variations of like A, B, C, D, E, F, G, whatever. It's like it's not very helpful because like no one's ever going to memorize that. It's like it's typical things. You know what order to fix based off of essentially from deep from inside to outside, right? That's typically how you fix most of the elbow issues. And so instead of trying to remember each classification system, which is probably only good for research, that's one I don't think is very helpful from a true like, hey, this is going to help me understand where I fix and what I fix what, right? So for me, that probably wouldn't change my practice because it's like I always know you fix from deep or from inside to outside because that's a lot easier to remember versus like, oh, this one had a radial neck and this type of coronoid and this and that and the order that you fix. But
Sure.
obviously, he's a very smart individual when it comes to elbow stuff. So it's always great to hear his concepts and what he's done and how he does things.
Yeah, and I think it's helpful way to teach it as well, Gottschalk. Not necessarily like memorize, like, but it's really helpful, I think, that column model to help teach it.
Yeah, but that's very none of that's new, right? That's all simple. That's all relatively all old from like O'Driscoll and Morey. It's the same concept of wrist columns of the way that they always look at it across the approach too.
Hmm.
Anybody else have anything? I know Wags has Ariella and is she's being difficult, like my son who's sitting underneath my desk who has refused to go to bed.
That was
Um,
a nice talk, Joanne.
yeah, it was actually very succinct and high yield. So it was very cool. Hopefully you enjoyed your time away.
Yeah, it was awesome. Thank you so much.
All right. I
All
think
right.
if that's it, we're going to let everybody adjourn.
All right, night, guys.
Bye.
Guys, great job.